السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. We'd like to welcome you all again. Thank you for being with us now for the last 3 days. Today is the third day of the official Best of ACR Convergence Saudi Arabia meeting in collaboration with American College for Rheumatology. So far, we have very successful 2 days. The first day we covered the most important abstract in rheumatoid arthritis, as well as the new American College of Rheumatology guidelines. We give a highlight on COVID-19 and rheumatic disease. And yesterday was a very successful day again. We cover myositis. We talk about the important abstract and we highlight about the increased mortality in myositis compared to the general population and cardiovascular disease as a common cause of death. We talk about myocarditis and how it can be detected by cardiac MRI, biopsy, and biopsy is still the gold standard. We covered most important abstract mentioned in American College of Rheumatology about systemic lupus erythematosus, and there is a highlight on low complement and lupus anticoagulant as important SLE specific risk factor for stroke. And there is a highlight about the urinary interleukin 16, CD163, as well as tissue growth factor beta that might predict histological activity in lupus nephritis. And we ended with a very interested talk about antiphospholipid syndrome and the treatment of catastrophic syndrome. Tonight, as well as we covered 2 days of pediatric rheumatology. It was very successful pediatric rheumatology coverage of best of ACR abstracts. And tonight we are joining both pediatric and adult. We'll have 2 sessions of 5 lectures. The first lecture, the first chairperson will be for the first session, Dr. Mansour Yahya Somali. Most of you know him. He's a consultant internist, rheumatologist at King Khalid Medical City. He's an assistant professor at College of Medicine at King Khalid University, Abha. Also, he's a board member of the board director of the Saudi Society for Rheumatology. And he got his clinical fellowship in rheumatology, systemic lupus erythematosus, as well as psoriatic arthritis from University of Toronto. So without further delay, the floor for you, Dr. Mansour.
Thank you, Dr. Hanan. Good evening, everybody, and welcome to this session, which I hope it will be informative and enjoyable. We have 2 topics in this session. The first lecture will be about Sjögren syndrome, new research and treatment of dental and ocular manifestations, which will be presented by Dr. Walid Hafid. And the second lecture will be about some updates in systemic sclerosis, and it will be presented by Dr. Muhammad Umair. We will proceed immediately with the first speaker, Dr. Walid Hafid. He's an assistant professor of medicine at the Faculty of Medicine, Al Qura University, consultant rheumatologist at the Arthritis and Rehabilitation Center and Noor Specialist Hospital in Mecca. He has clinical fellowship in adult rheumatology from the University of Toronto, Canada, followed by clinical research fellowship in Toronto Scleroderma program. He's a member of board of directors at the Saudi Society for Rheumatology and advisory board member for a few pharmaceutical companies. He has clinical and research interest in scleroderma and preclinical autoimmunity and has published several papers in these fields. Before we will start the talk, we would like to inform you that we will defer the A and Q to the end of the session. Dr. Hafid, the mic is yours.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mr. Chairman, for this very kind and warm introduction. It's a pleasure and an honor to sit here before you to present a few slides on the best that was presented in Sjogren's syndrome at the most recent ACR Convergence 2020. I would like to thank the Saudi Society for Rheumatology, headed by Dr. Hanan Reis, for this kind invitation. I also want to thank colleagues in the pharmaceutical companies for help sponsoring this meeting and trying to bring it into reality. I also want to thank colleagues in INCOR Medical Education in helping me putting the slides of this talk together. So I'll be talking about some new research and treatment of dental and ocular manifestations that were presented at the most recent ACR 2020 Convergence. And here are my disclosures, and it's important to mention that the slides of this talk were adopted from presentations that were presented by the researchers who presented the researches at the Convergence meeting. Now, over the next 20 to 25 minutes, I'll be walking you through the following learning objectives. So first, we will be discussing the implications of new findings that support clustering patients with Sjogren's syndrome into 4 groups based on symptoms. The second objective is to describe a recently developed composite endpoint for Sjogren's syndrome that can be used to determine efficacy in clinical trials. And we will finish up with review of the recommended treatments for dental and ocular manifestations of Sjogren's syndrome. So this is the first research that I'm going to present, and it was entitled as 4 distinct symptom-based clusters identified from the Sjogren's Foundation survey. As we know that there is a paucity of medications that are approved for the treatment of Sjogren's syndrome. And this is thought to be like multifactorial. One of the reasons is that many of our patients who present with Sjogren's syndrome, they tend to have only glandular manifestations, and a very small number of them presents with extra glandular manifestations. The other reasons is that many of the medications that have been tried in the clinical trials have shown failure to improve the common disease-related symptoms such as fatigue, sicca, as well as quality of life, anxiety, and depression. Furthermore, Sjogren's syndrome is, like many other rheumatic diseases, is considered like a heterogeneous disease, where manifestations vary from patient-reported observations all the way to the end organ involvement. So based on that, Dr. Tarn and her collaborative team identified 4 symptom-based clusters from 608 UK primary Sjogren's syndrome patients. This was like in 2019. And between these clusters, patients differed in their labs, transcriptomics, as well as a response to treatment. So the objective of the authors of this study was to verify symptom-based clusters in a larger US population cohort and report symptoms, medication use, quality of life, as well as organ involvement. So the survey that was used was a survey that was prepared or created in 2016 in a collaborative effort from Sjogren's Foundation as well as the Harris Poll, with involvement of expert physicians that deal with patients with Sjogren's syndrome and of course patients. Based on this, there were actually 4 symptom-based clusters identified, as you can see here in the bottom of the slide. And this was like based on the following, or the presentation and the severity of the following symptoms. So dryness, fatigue, pain, depression, as well as anxiety. And what happened is, based on the severity of these 5 domains, the clusters were as follows. So the first cluster was high symptom burden, which accounted for 30% of the patients of this cohort. The second cluster was high anxiety and depression, which accounted for 22%. The third symptom-based cluster was high dryness and fatigue, which accounted for 34% of the cohort. And the last and the fourth symptom-based cluster was low symptom burden, which accounted for 14% of the cohort. Now, as you can see here in this slide, that the following are the clinical or manifestations or the disease domains that were measured, and it was found that patients in the high anxiety and depression cluster, patients in the high dryness and fatigue cluster, and patients in high symptom burden clusters had actually higher percentages of these symptoms compared to the patients in the low symptom burden presented here in blue column. Furthermore, medications were also studied across these four clusters, and it was found, and I'll be focusing on the disease-modifying anti-rheumatic medications here. It was found that corticosteroids and hydroxychloroquine were actually used in higher percentages in the first three symptom-based clusters, which is the high symptom burden, high anxiety and depression, as well as high disease or high dryness and fatigue, compared to patients who were in the low symptom burden cluster. Surprisingly, there was no statistical significant difference in the usage of biologics as well as conventional synthetic DMARDs across these four symptom-based clusters. Now, in this slide, the authors also tried to assess the impact of this identification on the quality of life. And they found that, for example, when they studied the social security disability, which is here in Saudi Arabia similar as al-Daman al-Ijtimai. So what was found is that 15% of patients in the high symptom burden were actually on the social security disability, compared to only 1% who were in the low symptom burden. And the other domains were significant emotional burden to life, ability to be independent, as well as the relationship with family and friends followed actually the same path as the first one. Now, among all the clinical manifestations of Sjogren's syndrome, it was found that arthritis, mainly inflammatory arthritis, and lung disease, mainly interstitial lung disease, and neuropathy were statistically, significant in the high, dryness and fatigue cluster, high symptom burden cluster, as well as high anxiety and depression cluster compared to the patients who were in the low symptom burden cluster. Based on that, the authors of this project or study concluded that the following disease manifestations, dryness, fatigue, pain, depression, and anxiety, can actually identify four disease distinct clusters, which are actually based on symptoms. Now, these four clusters had some sort of overlap, however, demonstrated unique patient experiences when it comes to symptoms, medication usages, quality of life, as well as organ manifestations. And actually, the odds were more in favor of the high symptom burden patients. And the authors of this study are now engaging into more longitudinal cohort with enrollment of a larger sample size, putting into consideration the phenotypic disease differences in an attempt to identify future system cluster targeted therapies. So with this, I finished my first research project that was presented at the ACR 2020 Convergence. Now, moving on to the second research that was entitled as Development of Composite of Relevant Endpoints for Sjogren's Syndrome, or it was abbreviated as CRESS. Now, to start with the introduction, we know that primary Sjogren's syndrome is a heterogeneous disease. And we just mentioned a few minutes ago that there is no FDA-approved medication in the management of Sjogren syndrome. And furthermore, several randomized controlled trials, including the ASAP3 trial that was done recently, failed actually using the current disease activity index, which is called ESDI, that stands for the European Sjogren syndrome disease activity index. So this disease activity index failed to be as a primary endpoint, and as you can see here, that the responses in the placebo group were almost similar to the responses in the abatacept group when the ESDI endpoint was considered like as, or when the ESDI measure was considered as a primary endpoint. This heterogeneity of the disease actually mandates the development of a composite endpoint that might be more appropriate to demonstrate clinical efficacy in the clinical trials of patients with primary Sjogren syndrome. So the objective of the study team was to develop a composite endpoint for primary Sjogren syndrome based on the expert opinion and clinical trial data. And the methodology with which they conducted this study is, they recruited a multidisciplinary expert team from physicians that deal with patients with Sjogren syndrome, and then the expert in this team selected clinically relevant items and candidate measurements to include in the CRESS endpoint, and definition of response of the CRESS item was selected based on the clinical relevance of the according to the expert opinions, as well as some previously published data regarding clinically relevant important or improvement in the clinical domains. So this was like the composition of the CRESS responder or endpoint, in which there were like 5 items. So the first item was systemic disease activity, the second item was patient-reported symptoms, the third item was tear gland, the fourth item was salivary gland, and the last item was like serological. And in the upcoming few slides, I'll be walking you through some explanation of all these different CRESS items. So the first item is disease activity item, and it was like measured by the clinical ESDI. So the clinical ESDI actually differs from the ESDI that was tried in the ASAP3 trial, in which that it lacks the biological domain, as biological domain is actually separately assessed in CRESS. So the definition of the response in the clinical ESDI was a score of less than 5, which was actually reflecting low disease activity. Now, applying this definition, there were 45% responders to this item in the abatacept group compared to 27% of patients in the placebo group. With regards to the second item, which was patient-reported symptoms, so this was assessed with the ESPRI measurement tool. Now, the ESPRI measurement tool is a tool in which that is based on 3 clinical domains: fatigue, dryness, as well as depression. And this, response, like definition in this response was defined as decrease of more than 1 point or 15% or more from baseline. And by applying this definition, there were 58% of patients in the abatacept group that fulfilled this responder index, and only 22% in the placebo group that actually fulfilled this definition of response. The third item in the CRESS was like tear gland item, and this was actually used with the help of Schirmer's test as well as ocular staining score. Now, these measurements were defined as follows. So if there was like an abnormal score at baseline, or like in the OSS or in the Schirmer's, so an increase of 5 or more millimeters in the Schirmer's test, or decrease of more than 2 or equal like points in the ocular staining score was considered like a response. And if there was like a normal score at baseline in both Schirmer's as well as the ocular staining score, then no change to abnormal in either Schirmer's test or in the OSS was considered like a definition of response. Applying that definition, it was found that 45% met this response, and 32% of the patients in the placebo arm met this, CRIS-like item response. The last two items are the salivary gland item and the serology at the end. Now, with regards to the salivary gland item, this was actually defined with the help of unstimulated whole salivary flow rate and the salivary gland ultrasonography. And the definition of response was with regards to the unstimulated whole salivary flow rate by an increase of more than 25% or more. If the score is 0 at baseline, then any increase was considered like a response. On the other hand, with regards to the salivary gland ultrasonography, decrease of 25% or more in total Hosmer score was considered a positive response. Now, applying that response or definition of response to the ASAP3 trial, it was found that 58% of patients in the abatacept and 41% of patients in the placebo actually met the response in this CRIS item. Now, the last CRIS item was the serological item, in which rheumatoid factor, IgM and IgG rheumatoid factors were selected. Now, again, the definition of response was a decrease of 25% or more in the rheumatoid factor, and or decrease of more than 10% in the IgG. Now, applying that definition of response, 64% of patients in the abatacept arm and 19% of patients in the placebo arm met this, serological item, or CRESS responder item. So CRESS responder at 24 weeks in the ASAP3 trial was actually defined as the presence of at least 3 out of 5 items. So applying 3 or more items, it was found that 60% of patients in the abatacept arm and 19% of patients in the placebo arm were like cross responders, and this difference was considered statistically significant with a very significant p-value. Furthermore, if you look into this graph, you can see that there was statistically significance in the number of CRESS responders between the abatacept responders represented here in blue and the placebo responders represented here in red. This is again, so the so what happens if we have if you don't have the ocular staining score or the salivary gland ultrasonography, which are not available. Now, the rest, we know that we can perform them in the clinic as rheumatologists. For example, we can perform Schirmer's test. We can also calculate the unstimulated whole salivary flow rate in the clinic. So how about if we don't have these ocular staining score or the salivary gland ultrasonography? So what will happen to this responder index? So it was actually found that even in the absence of the ocular staining score and the salivary gland ultrasonography, the clinical CRESS response was still statistically significantly different across both abatacept as well as placebo arms. So to conclude, the authors of this study concluded that with the newly developed CRIS, it is possible to discriminate between active treatment and placebo treatment in primary Sjogren's syndrome patients. The CRIS consists of complementary tests. All items contribute equally to CRIS response, and external validation in global and independent randomized controlled trials will be the next step that the authors of this study will be performing. Now, with this, I come to the conclusion of the second, research that was presented in the at the ACR 2020 Convergence. Now, with regards to the treatment of dental as well as ocular manifestations. So here I have 2 more studies, which I'll finish in less than 10 minutes. So this was a study that was presented by Dr. Papas from Tufts School of Dental Medicine. And, there was actually a survey that was conducted by the Sjogren Syndrome Foundation, in which it was found actually that dental manifestations are very common in patients with primary Sjogren syndrome. And as you can see here, dry mouth is found in up to 92%. Mouth ulcers or sores are found in up to 66%. Trouble speaking is found in up to 61%. Tooth decay is more than 50% of the patients. Gastroesophageal reflux disease is in up to 45%. And of course, not to forget the infections, like, so once the saliva go down, the yeast infection goes up. So it's actually found in up to 26% of patients. And of course, sialolithiasis also is found in up to 15% of patients with Sjogren syndrome. So oral manifestations and dental manifestations are very common in patients with Sjogren's syndrome. And it's not only like the reduced amount of saliva that patients experience. It's actually more than that. So patients who suffer from reduced salivary flow, they are actually at an increased risk of increased infection. They can suffer from loss of free mineralization, of their teeth. And of course, because of the decreased lubrication, they usually suffer from trouble speaking as well as trouble swallowing. So it's not just like the reduced salivary flow that is experienced by the patients. This presentation was actually quite like a long presentation, in which Dr. Papas, covered some of the local treatment modalities that can help decrease the xerostomia symptoms in patients with Sjogren syndrome, such as remineralization of the oral cavity, as well as the use of some fluoride. And not to forget some, sugar-free gums or xylitol, gums, in which the use of these medications is usually aimed at increasing the salivary, production in the oral cavity. How about the medications? How about these, like the sialogogues or the secretagogues? So first of all, with regards to pilocarpine, there were like 2 studies that tested pilocarpine in patients with primary Sjogren syndrome. So one of these studies used like fixed dose of pilocarpine at a dose of 20 milligram daily, so which means like QID. And the other study used like a dose titration, in which it started at a lower dose, and then the dosage was up titrated to a total of 20 to 30 milligram a day. Both studies which were actually showed a significant improvement in terms of xerostomia in patients with primary Sjogren syndrome who used pilocarpine compared to the ones who were on a placebo. How about the other secretagogue or sialogogue, which is called cevimeline? Now, again, in this study, as we can see, when it was tested against placebo, there was like a statistical significant difference in the secretion or the increase in the salivary flow rate, especially the stimulated salivary flow rate after quite time. So for example, 12 weeks and 12 weeks. So within 12 weeks, there was like a difference in the stimulated salivary flow rate. So the author or the presenter of this presentation concluded her talk with the following tips for secretagogue usage, and I think I found them very useful. So the first tip was start low and go slow. So for example, start a pilocarpine at a dose of 5 milligram or cevimeline at a dose of 30 milligram, and then advance weekly as tolerated until side effects, and then you can actually down titrate the dose to maintain patients on the highest effective possible dose. May help, or these medications may help oral symptoms as well as other symptoms such as dryness of the skin, vaginal dryness, as well as eye dryness. She also mentioned that failure to respond to one drug does not necessarily mean that there will be a failure to the other drugs, and the same thing applies to the side effects. And secretagogues may be used to prevent complications of Sjogren syndrome. With this, I move on to the last talk, of my or the last present or the last research that was presented in the ACR Convergence 2020, and this was like a talk by Dr. Essen Akpek, and it was with regards to the ophthalmological manifestations in patients with primary Sjogren syndrome. So she started actually her talk with few research projects that highlighted on the impact of primary Sjogren syndrome in patients or the impact of dry eye on patients with primary Sjogren syndrome. And as you can see from this study that it is very common. 25.9% of these patients had actually an underlying rheumatic condition, and 50% of primary Sjogren syndrome patients were diagnosed as a result of initial evaluation of the dry eye. So actually, dry eye was the reason for further evaluation for patients with the possible diagnosis of Sjogren syndrome, and out of these 50% like 66 were actually testing positive for SSA and SSB. The other study was actually on the impact of ocular manifestations and burden related to Sjogren syndrome, and as we can see here that this study concluded that a dry eye is considered like the second greatest impact on patient's life after like fatigue in Sjogren syndrome, and it is actually as comparable to that of the other systemic manifestations in patients with Sjogren syndrome. She then mentioned few slides on the ocular manifestations or complications of primary Sjogren syndrome in men. And especially, in men, serious ocular manifestations and complications can happen. Not only that, in this slide, she also highlighted on the fact that, ocular manifestation can actually work as a predictor of, mortality in men with primary Sjogren syndrome. So, for example, in patients with keratolysis or scleritis, they had actually 2.3 times greater likelihood of death. And like a confidence interval of 0.5 to 4 due to like systemic sclerosis related due to Sjogren syndrome related complications. And lastly, she finished her talk with this dry eye management workshop, in which she leads this workshop in step fashion. So the first step is all about education, as well as identification of potential like environmental triggers, or like for example any offending systemic or topical medications. Then we can advance the treatment to go for like some ocular lubricants, or maybe usage of some warm like compressors. The second step is more towards like switching to non-preserved artificial tears, and trying to identify if there are any opportunistic infections that are associated with dry eye in patients with Sjogren syndrome. And she also proposes overnight treatments such as ointment, gels, and moisture. Continuation for the second step, if there is no benefit from the previous treatment modalities, then for example topical corticosteroids or topical, for example, cyclosporine can be initiated at this stage of treatment step wise approach. And then the third step is the use of oral secretagogues such as pilocarpine and cevimeline, or maybe autologous serum eye drops, or maybe therapeutic contact lenses, or what is also known as the scleral lenses. And the fourth and the final step in the management of dry eye is the use of topical corticosteroids for longer duration, or maybe the use of some disease-modifying antirheumatic drugs. If nothing works, then possibly surgical interventions can be of some help at this stage of the treatment. So to conclude my talk, and to provide like overall summary and key points, I would say that dryness, fatigue, pain, depression, as well as anxiety symptoms represent 4 distinct symptoms cluster groups that may be targeted with specific treatment in the future. A recently developed composite endpoint for Sjogren's syndrome may be useful in determining clinical efficacy of treatment. Dry mouth can be treated effectively with secretagogues and can reduce symptom burden for patients with Sjogren's syndrome. And lastly, proper treatment of dry eyes in patients with Sjogren's syndrome can improve quality of life and reduce risk of increased Sjogren's syndrome related morbidity and mortality. With this, Mr. Chairman and ladies and gentlemen, I come to the conclusion of my talk, and I would like to thank you for your kind listening.
Thank you very much, Dr. Hafid, for this update. Thank you, Dr. Hafid, for this update in the management of different manifestations of Sjogren's syndrome. We will proceed to the second topic and second lecture, which will be presented by Dr. Mohammed Umair, and he will talk about some updates in systemic sclerosis. Dr. Umair is a consultant rheumatologist and associate professor at King Saud University, graduate of Saudi Board of Rheumatology, and holds a subspecialty in both rheumatoid arthritis and systemic sclerosis from the University of Toronto, Canada. He led the task force to establish the specialized rheumatology clinics at King Saud University Medical City, where he is running rheumatoid arthritis and systemic sclerosis clinics. He is the founding president of the Charitable Association for Rheumatic Diseases. Dr. Umair has published more than 44 peer-reviewed articles and book chapters. Dr. Umair will talk about some updates in systemic sclerosis. Dr. Umair, the mic is yours.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. My name is Mohammed Umair. I'm a consultant rheumatologist in King Saud University. I would like to thank the scientific committee for inviting me to give this updates in systemic sclerosis that was presented in the recent American College of Rheumatology meeting. These are my disclosure. And of course, the slides were adapted from poster and oral presentations given by the original authors, which are available to the public. Now, in this presentation, I'm going to be talking about six different topics related to systemic sclerosis. The first one would be on nintedanib and interstitial lung disease. Then we're going to explore the scleroderma related microbiome. We're going to look at the heart of systemic sclerosis patients, and then we're going to see if defining the disease onset makes a difference in the outcome. And we're going to look at the long-term data of tocilizumab. And finally, we'll look at an important topic and interesting for most colleagues, which is the overlap syndromes. So the first study was presented by Professor Yannick Alnor from France, and this was looking at the data of nintedanib in patients with systemic sclerosis-related ILD. So as you know, the census trial was the largest ILD-related trial, which showed a positive result, and this has led to the approval of nintedanib for systemic sclerosis-related ILD, and has shown forced vital capacity preservation in patients using nintedanib. Now, in looking at the subgroup analysis, we have seen that whatever use of nintedanib has led to some preservation of the FVC. Now, the Census on study is an open label extension study, which has collected data from the census study and from a drug-drug interaction study, which is a small study looking at a few patients. So basically, in the Census on, they have gathered the data on these two trials, but they have actually looked mainly at patients who received placebo in the census trial, and then when they went into the arm of the nintedanib, so they were called the started patients. And here is the chart looking at the treated patients in census, and you can see in the middle where the patients who were received placebo and then complete the census trial and initiated on nintedanib, and here are the patients who received nintedanib in this small clinical trial. So you have a pool of 247 patients, and This is your placebo arm, and you could see that in every year you lose about 100 ml of the FVC. Well, patients who received nintedanib from the start have actually preserved about 60% of their loss of FVC. And here, in census on the patients who continued nintedanib and the patient who initiated nintedanib, they also have an improvement, a significant improvement from placebo. So basically, whether you start nintedanib early or late, it has a beneficial effect. And you can see this through this diagram where the loss of the FVC is almost the same in patients who have continued nintedanib or initiated it from the placebo arm. With basically no significant differences in the rate of side effects. So we really need to be cautious on these patients, and especially looking at the GI side effects. And again, I would just like to remind you that a subgroup analysis have shown that the combination of mycophenolate and nintedanib does not really add in the rate of side effects, and it's actually a fairly safe combination. So in conclusion, whatever dose of nintedanib, whenever started, might lead to some preservation of FVC loss in patients with scleroderma-related ILD, and nintedanib need to be recommended in any patient who has a significantly available fibrotic component. My second presentation that I have picked is about the gastrointestinal microbiome in patients with systemic sclerosis. So what do we know? We know that systemic sclerosis patients and patients with rheumatic disease, especially the ones that have the gastrointestinal tract as a major component of disease manifestation or disease pathology. So systemic sclerosis and spondyloarthritis are the two main diseases in rheumatology that have an altered microbiome, but you can still see altered microbiome in patients with lupus, with RA, and Sjogren's syndrome. So you can see that systemic sclerosis patients have a different microbiome than the normal population. Now, the aim of the study was to compare two different cohorts in view of the microbiome, but also to look at these characteristics if they alter also the microbiome. So the data were taken from two well-respected centers. One is the University of California, Los Angeles cohort, and the Lund University from Sweden. And if you look at the demographics, you could see that patients from the US have more diffuse disease, more interstitial lung disease, more scleroderma 70 autoantibodies, and have a mildly increase in the rate of bacterial overgrowth. While the patient and during cohort have more limited disease, less immunosuppressive agents, and more anti-centromere antibodies. Now you could see that there are some differences between the two cohorts, and this might be related to the ethnicity and the lifestyle, but also maybe because of the categorical differences in the demographics of these patients and their disease characteristics. But also importantly, you can see some differences in patients who have early disease and established disease, and obviously in patients who have small intestinal bacterial overgrowth, presence of ILD, use of immunosuppressive agents, they all alter the microbiome of patients. So it's not only that scleroderma patients have a microbiome profile different than the normal population, but also disease characteristics and disease duration, in addition to immunosuppressive agents or complications in the GI, might alter the microbiome. So this is again important, and this might open the door to perform further future studies. Of course, the microbiome in each patient population is different. So in Saudi Arabia, I would expect maybe a slightly different microbiome than the Caucasian. My next study is looking at the heart of systemic sclerosis patients. So we're looking at conductive problems, mainly heart block, and the rhythmic disorders. And this was done in the state of Minnesota. Now, the almost counties in Minnesota, they have one of the best inception cohorts in the world, looking at different rheumatic diseases, including lupus, Sjogren's syndrome, and systemic sclerosis. So they picked patients who were incidental systemic sclerosis patients between 1980 and 2016, and they matched them to patients who do not have systemic or normal people who have non-systemic sclerosis subjects in a ratio of 1 to 2. They looked at ECG and ECG filters in these patients. They actually got 78 incident systemic sclerosis patients and 156 non-systemic sclerosis patients. And interestingly, before the diagnosis of systemic sclerosis, patients who developed the disease had almost a significant more conductive disorder than patients with systemic sclerosis. And this is quite important because we see many patients with autoimmune disease developing some complications prior to the development of lupus, of disease. For example, in lupus patients, they found that patients who developed lupus in the future had more DVT attacks than normal people. So these disorders or these abnormalities might always be of importance to follow up these patients on the long term in order to detect them early, especially in a rare disease like systemic sclerosis. Now, arrhythmias were more common in systemic sclerosis patients. And when we look at the incidence of any conductive arrhythmic disorder, you could see that patients with systemic sclerosis have a significantly increased risk. Now, this is quite important because if you could see there is increased ECG changes, there is increased conductive problems, arrhythmic problems. But also, what is sad to see is that the odds ratio or the hazard ratio of developing a heart problem requiring defibrillator is 17 times than the normal population. So the risk of death is an important point to remember in patients who have heart involvement. And when they looked at the risk factors, they found that pulmonary hypertension and current smoking were the most important ones to increase the risk in both conditions. So remember to always examine the heart of patients with systemic sclerosis in view of rhythm, in view of structural problem, because these are all serious complications and there are limited treatment options for these patients. Then we're going to look at another important study that might change the way clinical trials are conducted in patients with systemic sclerosis. So basically, when a clinical trial is done in patients with diffuse systemic sclerosis and the modified Root-19 score is the primary outcome, the usual disease duration approach is defined by the first non-Raynaud phenomena symptom, and this is because of the reason that many patients develop Raynaud phenomena 10 or 15 years prior to the development of clinically evident disease in the skin or other organs. So this study looked at a large cohort from University of Washington and the University of Pittsburgh, both in the US. And they wanted to compare whether to use the first systemic sclerosis symptom versus the first non-Raynaud phenomena manifestation as the first manifestation to preclude to the disease duration, and then to look at the trajectory of the skin in view of regression or worsening to avoid the regression to the mean that happens as a natural history of patients with systemic sclerosis. So these two cohorts, they selected specifically patients who had less than 36 months of disease duration. They had a fairly high skin score, and a third of these patients had rapid deterioration, a third had intermediate, and a third had a slow deterioration. So this was a well-balanced distribution. And you could see which criteria used in view of the cutoff of disease duration. The trajectories are almost identical in both first onset of any symptom or the first non-Raynaud phenomena manifestation. It's exactly the same trajectory. And if you could see, if you pick the less than 18 months cutoff, you could see an initial increase, and this is the natural history of systemic sclerosis. So some patients have this increase despite of whatever you do in these patients. So this is an important point whenever you use a therapeutic agent that might alter the natural history of the disease. So the conclusion of this cohort is that regardless of whether you use the any manifestation or the non-Raynaud phenomenon manifestation, and the cutoff of the duration of 18 months is preferable because you have this rise in skin score, and whatever intervention might show you significant difference. And we're going to talk about that in the tocilizumab trial, hopefully, in the next slides. Now, it's also important to see that the longer the disease duration of the patient when enrolled in the clinical trial, the more likely that the skin score will improve even if he's in the placebo arm, which might affect the difference between the intervention and the placebo and might lead to a negative clinical trial. Next is about the tocilizumab program in systemic sclerosis. As you know, systemic sclerosis treatment with tocilizumab was shown in 2 clinical trials. The first one is the Fascinate trial, which was a phase 2 study on about 75 patients. Then the Focus, which is a phase 3 study, looked at a higher number of patients. Now, both trials have shown a very close p-value to significance, but were both negative, but showed a statistically significant preservation of the forced vital capacity in patients during the 24-week clinical trial duration in the primary outcome. Now, in this abstract, they are showing the 96-week data. Of course, the 48-week open label extension was also showing significant improvement. So this is the patient disposition, looking at the patient receiving tocilizumab and then enter the open label period in both trials. You could see here there is a significant drop in the skin score from baseline to the 96-week, reaching up to or down to 9.6, minus 9.6 points in the modified skin score. Just to remind you, a decrease in 4 to 5 points is meaningful or clinically meaningful. So this was significant. Now, remember to always be cautious when you look at open label studies, because you have to see that the number of patients is adequate to look at the data and analyze it and have a meaningful interpretation. Because if you have a significant drop in the open label extension, the data might be meaningless. Again, you could see this excellent response related to the lung, where at the open extension, more than 70% have no decline in their FVC. So you're not only treating the skin, but also preserving the lung in patients with ILD. And this proves that tocilizumab is actually a beneficial and safe drug in ILD, not only in systemic sclerosis, but also use it in patients with RA-related ILD. So basically, the open label extension have shown improvement in skin score, preservation of lung function, And I'm a big believer that tocilizumab works in skin disease, but unfortunately the primary outcome in the randomized period was negative for both studies. We'll see what Roche will perform. They're gonna perform a third study or not, or the tocilizumab is gonna be used as an off-label medication for systemic sclerosis. My last topic would be on the prevalence of overlap lupus systemic sclerosis, who fulfill the EULAR ACR criteria of lupus. So basically, they have looked at a cohort of 402 patients, and they applied the 2019 EULAR ACR lupus criteria. These are the symptoms of patients who have the systemic sclerosis with different manifestations. And then they found that about 10%, 40 patients had the criteria, with more patients were in the female gender, African American ethnicity, and were diagnosed initially to have lupus, of course, compared to a patient with pure systemic sclerosis. You can see that the anti-1-UR-1RMP was the only significant antibody in patients who have overlap compared to non-overlap patients. Other systemic sclerosis antibodies were similar. And you can see here the different manifestations, and of course the treatment hydroxychloroquine is not used in patients with systemic sclerosis or pure systemic sclerosis, but in lupus, of course, you're going to use more hydroxychloroquine. There is more use of steroids in patients with lupus because of the inflammatory manifestation, and patients who have diffuse disease had less chance to develop lupus related. Now, in the small cohort that I have been working on in our university, we have almost the same ratio. So we have about 38 systemic sclerosis patients from our cohort that started 4 years ago, and we have, out of these 38 patients, we have 3 with lupus scleroderma overlap. So in conclusion, scleroderma lupus overlap is not uncommon, so it affects about 10% of patients. The female gender, African American ethnicity, the limited subtype, and the anti-1-RMP are more significant in these patients. Of course, patients who have the overlap does not have a more severe organ involvement or increased mortality. Now, this study does not really give you this information. You need a larger, maybe collaborative study between centers to decide about that. But I think that the management of an overlap is always challenging, especially in view of the use of steroids and the risk of renal crisis. It's always important to re-evaluate patients on an annual basis to ensure that they do not have or do not develop new symptoms. We have seen many patients who started with RA and then ended up with scleroderma, or started with lupus and then developed dermatomyositis. And my last advice for my colleagues is the proper documentation at the time of diagnosis. So the colleague who sees the patient after 3 or 5 or 6 years knows exactly on what basis the patient was diagnosed. With that, I would like to conclude and give you my summary. So microbiome is different in scleroderma patients with different ethnicity, different disease characteristics, and might be affected by therapy. Heart block and arrhythmia are important to investigate and might be overlooked in patients with systemic sclerosis. Nintedanib confirms its safety and preservation of lung function, whatever is the way it is used, whether it's used early or later on. The duration of symptoms rather than the type of symptom predicts response trajectory, And finally, lupus scleroderma overlap is not uncommon and represents a unique disease phenotype that requires specific attention and management. With that, I would like to thank you and thank the Saudi Society for Rheumatology to organize the Best of ACR, inviting me as a speaker. And would like to thank the colleague from Encore Medical Education and helping in preparing the slides. Thank you.
We have a couple of questions. We are short of time. Just we will take a few questions. The first question is to Dr. Walid Hafid. The question is, in RA patients with secondary Sjogren presenting with melting cornea, how to differentiate if the cause is related to Sjogren syndrome complications or due to RA vasculitis, and how to treat them?
So I think this is a very difficult question, and I think it will require a whole session to talk about this. It's a challenging question, in which it's difficult to know which is which and what caused like the corneal, melting. However, it's similar when we deal with patients who present, for example, with interstitial lung disease, and then we don't know whether the interstitial lung disease is because of the rheumatoid arthritis itself or because of the medications. So I think in this situation, we need to make sure that whether or not we're dealing with probably like an active RA, or like secondary Sjogren syndrome, then probably this could be like a reason. Other than that, I think we will need more of like an investigational studies, for example, some local eye studies, slit lamp as well, some of the retinal studies to identify what is the cause. But I don't think there is one single way to identify whether the diagnosis is, or the corneal melting is because of the RA and secondary to Sjogren syndrome or because of the vasculitis. Dr. Muhammad, I think you are on mute. Dr. Mansour, you are on mute.
Thank you. Thank you, Dr. Hafid. The second question to you, what is the best option treatment for Sjogren patients with ILD?
Okay, so again, the same thing. I don't think we have any approved medication for interstitial lung disease in patients with Sjogren syndrome. We just heard Dr. Muhammad presented a very, exciting talk about the systemic sclerosis abstracts, and we just, celebrated like the approval of nintedanib in the treatment of systemic sclerosis and interstitial lung disease. Now, nintedanib is also approved for the treatment of connective tissue disease, interstitial lung disease, and some other, fibrosing phenotypes of the lung fibrosis. But per se, we don't have any treatment modality that can that is approved. However, we can follow the same path that we follow in patients with other rheumatic diseases. So, for example, what do we do in rheumatoid arthritis? We tend to avoid TNF alpha blockers. We tend to avoid a few other medications, especially the conventional synthetic DMARDs. We move more towards B cell inhibitor therapy such as rituximab. And who knows, maybe in the future, nintedanib will be one of the medications that will be used in the treatment of Sjogren syndrome associated interstitial lung disease.
Okay, good. And actually, you have answered also the second question raised by one of the audience. The question now to Dr. Muhammad Amer. When antifibrotic use in ILD should control the disease by using immunosuppressive therapy?
Now, the new approach is actually to treat patients with both immunosuppressive agents to halt the inflammation and also to halt the fibrosis that is occurring regardless of the inflammation. So, nintedanib combined with mycophenolate mofetil is a good combination to treat or to tackle both pathways. And this also adds to the clinical trials that is ongoing, including the scleroderma lung study 3, which they are combining pirfenidone and mycophenolate mofetil. So basically, if someone has 20% or more of lung fibrosis in their high-resolution CT scan, nintedanib would be an additional option. So we usually start with mycophenolate mofetil, but once a patient has 20% of fibrosis in their HRCT, you'd better add nintedanib to them.
The second question to you, which is also similar to the previous question, what is the best option treatment of ILD in systemic sclerosis patients when they have contraindication for cyclophosphamide?
Okay, so basically the options in interstitial lung disease in general, whether it is RA, lupus, Sjogren's syndrome, systemic sclerosis, is basically to stop the inflammation, preserve the lung, and halt the fibrosis. Now, mycophenolate mofetil has an antifibrotic effect because it works on the transforming growth factor beta. Cyclophosphamide has a similar effect. So you have cyclophosphamide, you have mycophenolate, are excellent drugs to treat interstitial lung disease regardless of the underlying disease. Then you have drugs like rituximab and now tocilizumab in view of biologics. And finally, you have nintedanib that is approved not only for systemic sclerosis, but also for any fibrosing interstitial lung disease and connective disease. So you can use nintedanib in patients with RA, you can use it in Sjogren's syndrome patients. The most important thing that you're looking at a phenotype rather than an underlying disease. So if a patient has a fibrotic disease in an RA patient or in Sjogren's syndrome patients, they might be candidate for nintedanib. Now, just to tell you that I don't usually start nintedanib, despite that we have a huge ILD cohort and we have an ILD center. I usually leave the decision of the antifibrotic to my colleague pulmonologist, but we always have this discussion on what to add on the side to control the inflammation and decrease the progression. So sometimes you're targeting to stop or resolve the ground glass appearance in the CT and improve the symptoms. Excuse me. But sometimes you're really preventing further lung function loss.
Okay, thank you for all the speaker on this session. We will conclude the session. Thank you very much, and we will proceed to the second session.
Thank you.
Assalamu alaikum. We'll start now.
Yes, Dr. Anan, you can go.
Without 1, 2, 3?
You can start directly. Thank you.
Okay. Okay, Assalamu alaikum wa rahmatullah. Welcome back to the second session of the third day. Thank you, Dr. Umair. Thank you, Dr. Hafid, for the excellent presentation. Thank you, Dr. Mansour, for the moderating the session. The second session will be moderated by Dr. Fahed Ghali Al-Anizi. All of you maybe know him. Dr. Fahed, he is the Vice Dean for Graduate Studies and Scientific Research at College of Medicine, Majma'a University. He's an Assistant Professor of Medicine, Consultant Rheumatologist, and Head of Internal Medicine Department in Al-Majma'a. He is board certified rheumatologist, and he got a clinical research fellowship in systemic lupus erythematosus from Toronto University. And he is a very additive to the director member of Saudi Society for Rheumatology. He is the General Secretary now of Saudi Society for Rheumatology. He's very active, and he is the co-chair of this official Best of ACR convergence. So welcome, Dr. Fahed, and you can start the break.
Thank you so much, Dr. Hanan, for your kind words. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening to everyone, and welcome you tonight on the third day of the Best of ACR Convergence 2020 Saudi Arabia. We have three presentations. The first presentation is Best of Abstract on Fibromyalgia. The second one is Evidence-Based Guidance for Optimizing Gout. And the third presentation is a New Targets in Osteoarthritis. All the presentations will follow by a live questions and answer in panel discussion. It's my pleasure to introduce the speaker for the first presentation. He is Dr. Naif Al-Ghanem. Dr. Naif, he is a rheumatology consultant. Also, he is a head of rheumatology unit at King Saud Medical City. I would like to welcome you again, Dr. Naif, and the microphone is yours.
Good evening. My name is Naif Al-Ghanem, and I will talk to you today about best abstract of fibromyalgia from ACR 2020. Next slide. I have no disclosures. Next slide. The slides I'm presenting today were adapted from presentation by Eri Polacek, Tian Liu, Jennifer Rogers, and Valerie Alouche. Next slide. There are four abstracts that I'm presenting today, and we'll discuss the following: the role of ultrasound for the assessment of PSA patient with fibromyalgia, the impact of fibromyalgia in the assessment of RA disease activity, is lupus nephritis associated with the reduced prevalence of fibromyalgia, and finally, the impact of COVID-19 outbreak on fibromyalgia patients. Next slide. The first abstract is titled as the role of ultrasound for the assessment of PSA patient with fibromyalgia. It was performed by Polacek from Tel Aviv Sourasky Medical Center. As we know, fibromyalgia is common in patients with inflammatory arthritis, including psoriatic arthritis, and ultrasound can be used to assess the disease activity in patients with inflammatory arthritis. The aim of this study was to examine whether ultrasound can be used in patients with PSA and fibromyalgia as an objective tool for disease assessment that is not influenced by fibromyalgia. Next slide. All the patients in the study fulfilled the Casper criteria. Fibromyalgia was diagnosed based on the 2016 ACR classification criteria. They looked at the following variables: 66-68 joints count, enthesitis, and fibromyalgia tender points. They also looked at widespread pain index and symptom severity score. They performed a detailed ultrasound evaluation, including 52 joints, 40 tendons, and 14 enthesis points. Next. 156 patients completed the study. Table 1 showed no differences in the demographic data between patients with fibromyalgia and without fibromyalgia, except for lower working and educational status among patients with fibromyalgia. Working status was 36.6 in patients with fibromyalgia versus 80.7. And educational status was 64% versus 83%. Next slide. The second table showed the differences in different clinical characteristics among the two groups. Patients with fibromyalgia were more likely to have higher tender joint counts, enthesitis score, a global physician activity score, as well as different disease activity score, including CPDI, DAPSA, PASTAS, as well as widespread pain index, symptom severity score, and tender points score. There was no differences in the treatments between the two groups. Next slide. There was no differences in the ultrasound scores between patients with fibromyalgia and patients without fibromyalgia. Next slide. The fourth table is looking at the correlation of ultrasound score with clinical score in the two groups. In patients with PSA without fibromyalgia, the ultrasound score significantly correlated with each clinical score of the disease. It correlated with CPDI, DAPSA, and PASTAS. Furthermore, these correlations were significantly higher for CPDI and DAPSA in patients without fibromyalgia compared with patient without fibromyalgia. There was no significant correlation between ultrasound score and clinical score in patients with PSA and fibromyalgia. Next slide. A multivariable regression analysis was performed, and fibromyalgia was significantly associated with high DAPSA of 17.6, high CPDI 4.4, and high PASDASA score. There was no significant correlation of the ultrasound score and fibromyalgia. Next slide. In summary, patients with PSA and fibromyalgia have high scores of clinical indexes of disease activity compared to those without fibromyalgia. Ultrasound score was similar between the groups. However, patients with PSA without fibromyalgia had a significant correlation of ultrasound score with clinical indexes. Presence of fibromyalgia was associated with high clinical indexes, but not with ultrasound score. Next slide. In conclusion, patients with PSA and fibromyalgia, ultrasound has significant additional value over composite scores in assessing disease activity, and ultrasound score was very helpful in differentiating between inflammatory disease activity and pain syndrome in patients with psoriatic arthritis. Next slide. The second abstract is titled as Clinical and Psychological Assessment of RA Patient with Fibromyalgia, a Real-World Study. It was performed by Tian Liu and colleagues at Peking University People's Hospital in Beijing, China. As we know, there is a high rate of fibromyalgia among RA patients, and the rate varies widely between 12% and 48%. The aim of this study was to assess the clinical feature and psychological status of RA patients with fibromyalgia in a real-world observational setting. Next slide. 202 patients with RA were enrolled between December 2018 and April 2019 from inpatients in Rheumatology and Immunology Department in Peking University People's Hospital. They looked at DAS28 score as well as short form 30S survey, HAQ score, hospital anxiety and depression scale, and the visual analog scale. Next slide. Among 202 RA patients, 42 patients were concomitant with fibromyalgia. The table showed a high DASA score and tender joint count in patients with fibromyalgia compared to those without fibromyalgia. DAS28 was 6 versus 4.4, and tender joint count was 16.5 versus 4.5. There was no differences between the two groups in regard to swollen joint count, morning stiffness duration, CRP, and ESR. Next slide. Patients with fibromyalgia were more likely to have high HAQ score, visual analog scale, and SF36 score. Next slide. The conclusion of this abstract is that fibromyalgia is more common than generally considered in RA patients. RA patients with fibromyalgia result in high disease activity. RA patients with fibromyalgia have lower quality of life, and DAS28 is overestimated in patients with fibromyalgia. In those patients who don't achieve remission, we should consider fibromyalgia in this group. Next slide. The third abstract is titled as lupus nephritis is associated with the reduced prevalence of fibromyalgia. The study was performed by Jennifer Rogers from Duke University Hospital in Durham. As we all know, SLE patients have a poor health-related quality of life. The differences in the predominant causes of decreased health-related quality of life across subgroups of SLE patients are not known. Fibromyalgia prevalence is very high in SLE patients, affecting between 20 to 65 patients. And the aspect of fibromyalgia among patients with lupus nephritis is unknown. Next slide. Therefore, the aim of this study was to evaluate the self-reported symptoms of fibromyalgia and mood disorder in patients with and without lupus nephritis. Next slide. The study is a cross-sectional study of SLE patients who met the ACR 1997 or SLEC 2012 criteria. Patients were enrolled in Duke University Registry from June 2018 to November 2019. They looked at Systemic Lupus Activity Questionnaire and Patient Health Questionnaire. Patients were diagnosed with fibromyalgia based on the 2016 ACR fibromyalgia criteria, and patients were divided into 3 groups: active nephritis group, remission nephritis, and fibromyalgia group. Active nephritis was defined as urine protein creatinine ratio of more than 500 milligram and or active urine sediments. Remission group were defined as a history of lupus nephritis with urine protein creatinine ratio of less than 500 milligram with active sediment. Fibromyalgia patients were defined as patients with widespread pain index of more than 7 and symptom severity score of more than 5, or widespread pain index of more than 4 and symptom severity score of more than 9. Next slide. In the cohort, 224 patients were included with a mean age of 40. The majority of patients were female, 93%. 11% had active nephritis, 35% had nephritis in remission, and 54% had no history of nephritis. Of nephritis patients, 22% had membranous class nephritis, 48% had proliferative nephritis or mixed type of lupus nephritis, 3% had class 1 or class 2, 5% underwent renal transplant, and 6% were on dialysis for end-stage renal disease. Next slide. Patients with nephritis were more likely to be younger. Active nephritis group, mean age was 34. Patients with lupus nephritis in remission, 38.9, and patients with non-nephritis were 47.1. Patients with lupus nephritis were more likely to be of Black race than patients without lupus nephritis, and patients without lupus nephritis were more likely to have less social support than patients with lupus nephritis. The social support level was 58% in patients without lupus nephritis versus 75 and 76% in patients with active and remission lupus nephritis. Next slide. The prevalence of fibromyalgia was higher in patients without lupus nephritis of 21% compared with active nephritis 30% and lupus nephritis in remission 3%. As expected, patients who have lupus nephritis were more likely to be on steroid, 97% in active nephritis group and 50% in lupus nephritis in remission group versus 28% in patients without lupus nephritis. The use of Plaquenil, antidepressant, gabapentin, muscle relaxant, and narcotics were similar between the three groups. Next slide. This diagram is showing the different clinical manifestation of fibromyalgia among the three groups. The patient without lupus nephritis is represented in the purple bar. Patient without lupus nephritis were more likely to have fatigue, brain fog, and sleep dysfunction as seen in this diagram. There was no differences in anxiety and depression between patients without lupus nephritis versus patients with nephritis. Next slide. The conclusion of this study is that patients with lupus nephritis report less fatigue, fibromyalgia, sleep disorder, and cognitive dysfunction compared to patients without lupus nephritis. The differences in social support could potentially mitigate fatigue and fibromyalgia in nephritis patients. There was no differences in anxiety or depression between the three groups, which may suggest that fibromyalgia can happen independently of mood disorder. Next slide. And because it's not 2020 without talking about COVID-19, the fourth abstract is titled as Pain in Time of Corona, Impact of COVID-19 Outbreak on Fibromyalgia Patients. The study was performed by Alush and colleagues, and the aim of the study was to evaluate the physical and mental health of fibromyalgia patients during the COVID-19 outbreak and to identify the related protective and risk factors of fibromyalgia. Next slide. An online survey was published in May 2018 and was sent to fibromyalgia patients registered with the Fibromyalgia Association. The survey was sent 2 months after the lockdown and social distancing due to COVID-19 outbreak. The survey included information about demographic and socio-economic characteristics. It also included information about access to medical services, as well the level of anxiety and depression among patients, as well as coping strategies and perceptions of social support. They asked patients to score the following: widespread pain index, symptom severity scale, insomnia severity index, and patient global assessment. Next slide. 262 fibromyalgia patients were recruited. Only 233 patients completed the entire study questionnaire. 43% of the patients stopped contact with their treating physician during the outbreak, and 98% were forced to discontinue complementary and alternative treatment. Patients who underwent psychotherapy continued the online follow-up. Among patients with fibromyalgia, 41% of them were treated with medical cannabis. Of those, 30% were forced to discontinue the treatment, which was associated with a high score of widespread pain index and symptom severity scale compared to patients who continued cannabis treatment. There was a high level of anxiety and depression correlated with high level of pain, disorder, and subjective perception of deterioration. Next slide. A higher score of social support and positive life approach were correlated with less anxiety and depression among fibromyalgia patients. There was also lower level of pain and less sleep disturbance among those patients who received high social support and a high level of positive life approach. Avoiding coping styles such as denial and behavioral disengagement was strongly associated with high level of pain, sleep disturbance, anxiety, depression, and subjective perception of worsening. Next slide. The conclusion of this abstract is that fibromyalgia patients develop a high level of anxiety, depression, and sleep disturbance during the COVID-19 outbreak. Worsening of symptoms are related to difficulty in accessing medical and complementary treatments, as well as specific medications such as medical cannabis. Next slide. Summarizing the 4 abstracts that I have presented today, ultrasound can help in differentiating between inflammatory disease activity and pain syndrome in patients with psoriatic arthritis. Fibromyalgia is more common than generally considered in RA patients. Patients with lupus nephritis reported less fatigue, fibromyalgia, sleep, and cognitive dysfunction compared to patients without lupus nephritis. And finally, COVID-19 outbreak led to high level of anxiety, depression, sleep disturbance, and pain among fibromyalgia patients. Thank you for listening.
Thank you so much for Dr. Naif regarding his informative presentation, which is as usual from him. So just for time issue, I would like to collect all the questions from the audience, and I will ask all the speakers at the end of the 3 presentations. So it's my honor to introduce the next speaker. He is Dr. Badr Al-Mehmadi, and he will talk about the evidence-based guidance for optimizing gout. Dr. Badr, he is a rheumatology consultant. Also, he is assistant professor of medicine and head of community medicine and public health department at the Najma University. Dr. Badr, he has a Canadian fellowship in rheumatoid arthritis and systemic sclerosis at the University of Toronto, Canada. So, Dr. Badr, I would like to welcome you again. Please, the microphone is yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hi, everyone, and welcome to this review of the gout management according to the ACR 2020. I would like also to thank the organizing committee for their excellent execution of this webinar. My name is Badr Al-Mehmadi. I'm an assistant professor and a consultant rheumatologist in Al-Majma' University. And I'll be talking about the evidence-based guidance for optimizing gout management. I have nothing to disclose. And those slides were adapted from different presentations by several rheumatologists in the late ACR 2020. In this talk, we'll be reviewing the latest ACR 2020 gout management guidelines. We'll be reviewing some of the supporting evidence behind the recommendations, and we'll go through some selected abstracts that have been posted in the ACR 2020 on this subject. So going back to the previous guidelines that have been adapted through the years, over the past decade, we had several guidelines that have led the management of gout in our practice. We have the ACR 2012, which started adapting the targeted to treat role in treating patients with urate lowering agents. The targets were less than 6 milligrams and 5 milligrams if the patients had severe gout. Basically, they had different scenarios, and then the treatment was titrated based on the severity of symptoms related to those scenarios, and we'll go through them in a minute. We also have the EULAR 2016, which had also adapted the targeted to treat strategy with the recommendation of keeping in mind the comorbidities that the patient might have. We also have the American College of Physicians 2017 guidelines that was led by the primary care physicians. There was some controversy in those guidelines where they said that the target to treat was not adequately investigated. The treatments were to avoid symptoms and not to have any targets to look forward to when treating and titrating the treatments. But in terms of treating the flares, that was aligned with the rheumatology recommendations. And finally, we have the ACR 2020, which was recently published with a group of recommendations that were targeted for the target to treat management strategies. Now, when going through the ACR 2012 gout guidelines, there was about 9 case scenarios which have categorized the patients into mild, moderate, and severe chronic tophaceous gouty arthropathies. And based on that, the different modalities of treatment were changing through the scenarios. And that was the guide for all clinicians to go through changing the treatments and switching from one medication to the other. That would guide them into approaching different case scenarios in those patients. Now, in the ACR 2020 guidelines, there was a lot of PICO questions that have been formulated, and then there was some outcomes that have been selected. Systematic reviews were conducted to come up with those outcomes in the studies. And then there was some rating and grading of the overall quality of evidence for those outcomes. And based on that, the panel that had put down the guidelines have formulated the recommendations into either for or against the starting or stopping some of the treatments. And also the recommendations were divided into either strong or conditional based on the strength of the evidence. The questions consisted of 30 questions on urate lowering therapies, 7 questions on lifestyle, 2 questions on alternative medicine, 8 questions on asymptomatic hyperuricemia, and 10 questions on flares, with a total recommendations generated of 42. There was 16 largely established recommendations, buttressed the new evidence, and they were rated strong. Some lower quality recommendations were labeled as conditional recommendations. Basically, the recommendations were categorized into 4 major groups: indications of starting the urate lowering therapy, and how to initiate the urate lowering therapy, urate lowering titration, and the urate target, and when to switch the medications between each other, and what were the contraindications for certain medications when choosing the best treatment for patients. Now, I would just like to stress on a few points that have been in the recommendations. First, as an indication of urate lowering therapy, any patient with tophaceous gout or tophies was strongly recommended to start on urate lowering therapy. Any patient with any radiographic damage attributable to gout was also strongly recommended to be started on urate lowering therapy. Any gout flares of more than 2 per year was also an indication. Now, if it was less than 2 per year, there had to be some other conditions associated with that, like the chronic kidney disease of stage 3 or above, a serum urate of 9 milligrams per deciliter, or urolithiasis, and that was a conditional recommendation to start the urate lowering therapy. Now, when to start the urate lowering therapy, the recommendations have strongly recommended starting allopurinol over any other urate lowering therapy, as it was the preferred first line agent for all patients, including those with chronic kidney disease of stage 3 or above. They also recommended strongly the xanthine oxidase inhibitor over probenecid for those patients with chronic kidney disease stage 3 or above. Allopurinol and febuxostat were strongly recommended to be started on lower doses, and then the doses were changed according to the targets and their reach. It was also recommended strongly that initiating concomitant anti-inflammatory prophylaxis therapy such as colchicine, NSAIDs, and steroids were strongly recommended. And the duration of therapy was proposed to be about 3 to 6 months rather than less than 3 months. There was an interesting also point about the decision to start the urate lowering therapy while the patient was having a gouty flare. Now, as we all know, that there was some studies suggesting that starting the urate lowering therapy during the flare might increase the duration and the severity of that gouty flare. Basically, those conditional recommendations came out from some of the suggestions that if a patient is started on the urate lowering therapy while they are on the gouty flare along with the treatment for the gout flare, that would motivate them to continue taking the treatment and not stop it because they have witnessed the effect of subsiding the inflammation. The other point that they have also backed up their suggestion with is that there was some difficulty getting patients back to the clinic to start the urate lowering therapy after the duration of a gouty flare. So because some of the patients were not coming back as they were not motivated because they weren't having any symptoms. So that made them face a difficulty of maintaining a low uric acid level for those patients, and that led them to more flare-ups. At the same time, there were 2 randomized controlled trials and 1 observational study that have suggested that starting the urate lowering therapy during the gouty attack did not seem to extend or increase the severity of the gouty flare. There was also strong recommendations against starting pegloticase as a first-line therapy, and part of the reason for that is the immunogenicity that is commonly associated with this medication. And we'll talk about some of the trials that have been looking for solutions for this issue. There was also a strong recommendation about starting a target to treat strategy in starting the patients on medications and titrating the doses of those medications in order to reach the optimum serum uric acid values. In terms of switching the medications and contraindications, we all know that there was the CARES trial that have suggested that febuxostat will increase the mortality of cardiovascular events in patients who were taking it. So for that, there was a conditional recommendation to switch febuxostat if a patient comes with coronary cerebrovascular disease or any cerebrovascular event when the patient were on this kind on febuxostat. So ACR reviewed and newest randomized controlled trial data provided a robust evidence to support that urate lowering therapy impacts clinically meaningful outcomes in gout, and by that we mean the uric acid burden in terms of the deposition of crystals and the presence of tophi, along with the joint structural effect and damage such as synovitis and erosions, and the acute flares in terms of gout symptoms. Some of the supporting evidence for that is a few studies. One of them have mentioned the comparison between febuxostat and placebo in measuring the synovitis score by MRI over a period of 2 years. And as we can see in the first graph, there was a significant difference in the mean change from baseline in terms of synovitis detected by MRI, and also in terms of gout flares in the febuxostat group. We can see that there was some statistically significant difference starting from the 6 months period to the end of the study compared to the placebo. Now, another study was a randomized controlled trial where they have compared the rheumatology nurse-led target-to-treat strategy in treating gout patients versus the primary care approach, where they were targeting the symptoms rather than targeting the certain targets in treating gouty patients. We can see that the serum urate level have dropped down significantly in the first group, where they were going with the target treat to target strategy, compared to the primary care group, where they have maintained a uric acid level of around more than 400. We can also see that the serum urate concentration have been significantly dropping over the 2 years period in patients with the nurse-led intervention compared to the primary care patients. And for that also, the number of flares have significantly dropped to 1.5 flares in the nurse-led group compared to 2.5 in the primary care group. The dual energy CT was also used to detect the change in urate crystal deposits over a period of 18 months in patients who were treated with xanthine oxidase inhibitors, and it had shown that there was a significant drop of about 30 to 40% in those patients over a period of around 2 years. And that was in the MTP joints, the Achilles tendon, and in the midfoot. And that is one of the uric acid burden outcomes that have been proposed to be looked after in the recent recommendations. There was also supporting evidence that the xanthine oxidase inhibitors would improve the cartilage surface crystal deposits in the form of double contour seen by the ultrasound studies. And that was the first to improve over a period of 12 months, followed by a slower improvement and decrease in the tophi presence and the aggregates in the tendons and entheses. Now, allopurinol dose escalation was also checked compared to the joint erosion score done by CT, and we can see that there was two groups. The first group was a control group where the allopurinol continued to be on a similar level without any major difference in the dose, comparing that to a dose escalation starting from about 265 milligrams going up to 400 milligrams. We can see that the joint erosion score have been rising over those years in the control group, where it was maintained around the baseline in patients who have an escalated dose of allopurinol. Now, for every recommendations, there would always be some gaps that would initiate the improvement of those recommendations for the future. In those recommendations, improving the precision and meaningful outcomes in gout management was a true mark of consideration. Allopurinol and febuxostat, while they were sufficient for urate as a urate lowering therapy in most, what were they truly sufficient for in gout by itself? And by that, when we see gout as a whole, when we see the joint damage, the erosions, and the synovitis, how would they be targeting those outcomes? And when we compare that to the treatments and studies that have come out for rheumatoid arthritis. Refinement of the serum urate target and anti-inflammation was also a point to be considered for the future. How low should we go with the uric acid level? Now, there was some studies that have suggested that a maintenance of a low uric acid level of less than 3 over a period of time might be associated with some neurodegenerative disorders. So that would need some looking into. How quick should we lower down the urate level, and if that had any clinical significance on the outcome of gout damage to the joints and tissues. How long should we keep treating patients with urate lowering agents, especially if they show improvement and a sustained improvement in their symptoms. And then if we look into the other medications used for gout, like colchicine and interleukin-1 beta inhibition in gout, and what would their effects would be on the cardiovascular conditions, renal conditions, and hepatic disease, as we know that they are closely associated with patients with gout, and that might hold some of the mortality in those group of patients. Precisely how do we treat hyperuricemia in gout with stage 4 chronic kidney disease, which is a challenging part of treating gout? Adding the pharmacogenomics into the urate lowering therapy, as the latest studies over the past decade have detected that ABCG2 Q141K genetic variant had an association with the as a factor for worsening gouty arthritis in patients, and it might also play a role in developing gout in those patients, and we'll talk about this in a minute. The role of and use of uricosurics, especially in combination with xanthine oxidase inhibitors, and the addition of immunomodulation suppression therapy, especially with medications like pegluticase to reduce the immunogenicity. Now, the ABCG2 gene is substantial in the urate secretion in kidney and gut through the urate homeostasis, and that makes it play a major role in contributing to the effect of uric acid and its increase in the body, forming gouty arthritis. There was 2 large genome-wide association studies that have detected that there was a large impact of ABCG2 in multiple groups of populations, especially the East Asian group and the Mexican American group. The variant was found in about 10% of patients who were white, 4% in blacks, about 20% in Mexican Americans and Native Americans, and about 30% in East Asian population, with more than 50% in the Chinese Han group and the Japanese group with gout, making it a significant factor for gouty arthritis in those populations. So are we going to start screening patients for this genetic variant, especially in those groups, as well as how we're adapting the screening of HLA-B5801 for allopurinol hypersensitivity in the high-risk group, like the East Asians and the African Americans? Now, elements of gout, like a dysregulated uric acid balance, urate crystal deposition, and arthritis, have so many factors contributing to them. So one of the future recommendations is to look into comorbidities, exposures, genomes, and signaling and transcription pathways as factors that might play a major role in those gout elements. And if we can start targeting all those factors, that might also help into improving the outcome in those patients. Mortality is the ultimate comorbidity and outcome measure in gout and hyperuricemia. And for that, we see that the initiation of allopurinol has a major impact in reducing the mortality in those patients. We also know that colchicine plays a major role in cardioprotection, even in small doses like 0.5 milligrams per day. And we can see that there were 3 major studies that have compared colchicine to placebo, along with the basic therapeutic measures in patients with cardiovascular disease. And it showed that there was a major improvement in the patient's outcomes when using this medication. Now, in conclusion of these recommendations, the guidelines on urate-lowering therapy indications were reliable as an overall. The ACR reviewed and newer randomized controlled trial data supported the urate-lowering therapy impact on clinically meaningful outcomes in gout. And precision therapy was also recommended to be looked into when prescribing with specific comorbidities, and to take into consideration the pharmacogenomics, uricosurics, and recombinant uricase use was also recommended to be looked into, and improving the joint damage outcomes such as non-synovial organ disease and mortality, and include that in the future recommendations. Now, going through some of the selected abstracts in the ACR that were related to the subject, we can see that there was a long-term cardiovascular safety of febuxostat and allopurinol in patients with chronic gout. Now, this has arisen after the CARES trial, where they have found that there was a higher mortality rate in patients who were receiving febuxostat compared to allopurinol. Now, this study have been a prospective randomized open-label blinded and open endpoint trial of febuxostat versus allopurinol in patients with chronic symptomatic hyperuricemia in the UK, Denmark, and Sweden. A total of about 6,128 patients were enrolled. Half of them were in the allopurinol group, and the other half were in the febuxostat group. And the study showed that in both the on-treatment and intention-to-treat analysis, febuxostat was not inferior to allopurinol over the period of 4 years for the incidence of the primary endpoint. Around 7.2 patients died in the febuxostat group compared to 8.6% in the allopurinol group. So they have concluded that febuxostat was not inferior to allopurinol therapy for the primary cardiovascular outcome, and long-term use of febuxostat was not associated with an increased risk of death compared to allopurinol. Another study that have looked into co-treatment of methotrexate with pegloticase. This was because of the increasing immunogenicity found with pegloticase in patients who are treated with it. So the group of patients have been started on methotrexate 50 milligrams weekly for 4 weeks prior to the start of pegloticase, and then both medications have continued for a duration of 52 weeks. The study have showed that co-treatment with methotrexate resulted in more concentrations of pegloticase compared to monotherapy, and a major factor as an explanation for that is the reduction of immunogenicity with the use of methotrexate in those patients. Another study that have looked also into methotrexate co-treatment with pegloticase. They have started with the same regimen of starting 50 milligrams of methotrexate 4 weeks prior to the start of pegloticase, and they have initially started with 24 weeks, but then extended it to 52 weeks. The primary outcome was the proportion of responders during the first 6 months period, where they have been considered if they had a uric acid level of less than 6 milligrams per deciliter for more than 80% of the time monitored. They started with 14 patients. 11 patients were considered at 6 months pegloticase responders, and 3 were non-responders, where they have discontinued pegloticase after 2 consecutive levels of uric acid more than 6. Out of the 11 patients who have been taken into the second phase of the trial, 1 did not extend to 52 weeks. 2 have discontinued pegloticase due to meeting their treatment goals and have continued taking allopurinol as monotherapy. And the remaining 8 patients have continued pegloticase methotrexate co-therapy and remained responders for the whole 12 months period. In terms of gout flares, about 93% of patients developed it in the first 12 weeks, and that have dropped down to 25% after the completion of the study. 1 adverse event was noted of sepsis in 1 patient in the first 6 months, and there was no new safety issues observed. As a conclusion of the study, the 6 months response rate of methotrexate pegloticase therapy was about 78%. Responders at month 6 who remained on treatment continued to be responders at 12 months, remaining with serum uric acid below 1 milligram per deciliter. So methotrexate pegloticase co-therapy was well tolerated over a 12-month period with a reduced incidence of gout flares over time. Another study have looked into pegloticase with azathioprine, where they have also tried to limit the induction of anti-drug antibodies caused by pegloticase in those patients. They started with azathioprine of 1.25 milligram per kg for the first week, then that doubled to 2.5 milligram per kg for the remainder of the trial. Then they have started using the azathioprine with pegloticase after the second week for a period of 24 weeks. The primary endpoint was the persistence of lowering of serum urate to less than 6, at least in 3 consecutive study visits. The patients who had increased in urate levels of more than 6 on therapy did not receive any additional pegloticase, and they were considered failing this kind of treatment. So they started with 12 patients. 6 have completed the full course of the treatment. There were also 2 other patients who have remained on a low urate level. There were a total of 4 patients who discontinued the study, and they were not evaluable for the endpoint, as 2 of them lost the urate lowering effect after 2 doses of pegloticase. 1 of them experienced an infusion reaction during the first dose, and 1 had subjective symptoms of azathioprine intolerance with no lab abnormalities. So there was no adverse events related to azathioprine reported, and gout flares were noted only in 6 of the subjects, with a mean of 1.5 flares per patient with flares. As a conclusion, azathioprine was considered safe in subjects with chronic refractory gout and appears to increase the frequency of subjects experiencing long-term response to pegloticase. Another study, which was a double-blind randomized controlled trial, have studied mycophenolate mofetil co-therapy with pegloticase. And this was the first randomized controlled trial to demonstrate prolonged efficacy of pegloticase with co-administration of an immunomodulatory agent. The patients were recruited for a period of 18 months. Only in the first 12 months, the patients have been divided into receiving placebo or mycophenolate mofetil. The endpoints included the primary endpoint of proportion of subjects achieving and maintaining a serum urate of less than 6. And the secondary endpoint was assessing the 6 months durability of immune modulation after discontinuation of the MMF at 12 weeks period. And then the adverse events was also looked into. 86% of the MMF group achieved the primary outcome, and compared to only 40% in the placebo group. And that was sustained for the whole period of 24 weeks, where in the placebo group, the percentage went down to 30%. In terms of adverse events, it was comparable between the 2 groups. But the MMF group had a slightly higher adverse events compared to the placebo group. They developed a bit more musculoskeletal adverse events. They were the only ones with respiratory and infections adverse events compared to the placebo group. The placebo arm had greater percentage of infusion reactions, which might be correlated to the immunogenicity of the pegloticase. As a conclusion of the study, we can see that the percentage of uric acid maintenance for a level of less than 6 milligrams per deciliter was higher in the MMF group compared to the placebo. And that was statistically significant and clinically meaningful impact on the proportion of subjects achieving this kind of level at the end of the trial. There was also another study that have looked into the trends of the usage of co-therapy with pegloticase over the period of 2015 until 2019. And they have looked into all the medications used as co-therapy in different practices. They have found that about 30 million patients were diagnosed with gout and chronic kidney disease in the database that was studied. Patients who were prescribed methotrexate or azathioprine within 60 days before or after the start of pegloticase were included in the study. The co-therapy rates were consistently low between the period of 2015 and 2018, but there was a marked increase in this rate at the beginning of 2019, and that is correlated to the study where it was shown that methotrexate increased the response rate with pegloticase. The majority of patients were started with immunomodulator within 30 days of the beginning of pegloticase infusion, and methotrexate was prescribed more than azathioprine in those groups. So as we can see in the graph, there was a marked increase in the use of immunomodulators from the period from 2008 until the end of 2019. Methotrexate was used more than azathioprine, and the physicians appeared to be using DMARDs with increasing frequency in patients who were uncontrolled gouty patients who were indicated to be started on pegloticase. Thank you for your time, and I would be happy to receive any questions.
Thank you so much for Dr. Badr al-Mahmadi about his scientific updated presentation. I would like to move to the next speaker. It's my honor and a pleasure to introduce for you Dr. Faiz al-Harthi, and he will present the new targets in osteoarthritis. Dr. Faiz al-Harthi, he is a consultant, rheumatology consultant, head of rheumatology unit, and also he's a director of ambulatory care services at King Abdulaziz Medical City in Jeddah, Ministry of National Guard. I would like to welcome you again, Dr. Faiz al-Harthi, and the mic is yours.
Assalamu alaikum wa rahmatullah. I am honored and pleased to present at this meeting the best of ACR Convergence 2020 Saudi Arabia. I would like to thank the Saudi Society of Rheumatology for their kind invitation. My talk will be on new targets on osteoarthritis. I have no disclosures. Acknowledgements. Slides adapted from two great presentations by Professor Tonia Vincent and Professor Philip Conahan given at ACR Convergence 2020 virtual conference, in addition to other interesting abstracts presented at the same meeting. Learning objectives. Recognize new advances in preclinical osteoarthritis studies. Identify the concordance and replication between preclinical and clinical studies in osteoarthritis. Discuss updates regarding future promising new novel osteoarthritis targeted therapy. The presentation will be in two parts. The first part will concentrate on preclinical studies, and the second part will be on clinical data. On preclinical studies, osteoarthritis is usually induced by trauma in mice animals. This is done either by destabilization of the medial cruciate ligament, or less commonly by medial meniscus resection, and in rare situation, cruciate ligament transection. Advantages and disadvantages of surgical models. Advantages include we have a genetically homogeneous animals. The environment is controlled with regard to diet, temperature, activity, and age. We have a time 0, so we would know the initiation, the start of the disease, and it is relatively cheap and can be genetically modified. The disadvantages include the study design with regard to power and bias. We all know that mice animals are different from human. In mice, it is post-traumatic versus an age-related degeneration in humans. And finally, mice usually hide the pain with time. They are called predation animals. Osteoarthritis pathogenesis. In osteoarthritic joint, we have shear stress. This will cause mechanoinflammation and consequently tissue inflammation locally in the joint at cellular level in the presence of local cytokines like metalloproteinases and others. Then we'll have pain in the joint. Both tissue inflammation and pain will prevent tissue repair, which is very important for cartilage regeneration. In the upcoming slides, we will talk about 4 important preclinically molecular identified OA targets. This includes the Wnt pathway, which includes 19 genes in mammals, the NGF, nerve growth factor, molecular pathway, the fibroblast growth factor receptor 3 pathway, and finally interleukin-1 TNF pathway. For each pathway, we will look for preclinical OA studies and clinical data, whether there is concordance, validation, and replication of this data. In these slides, we have the Wnt molecular pathway. In the left-hand side, we have the preclinical studies. Here we have 3 studies demonstrating a beneficial effect of antagonizing Wnt molecular pathway in mice animals with prevention of osteoarthritis progression. On the right-hand side, this is found also supported in clinical trials like this famous study, a novel Wnt pathway inhibitor, small molecule 04690 for the treatment of moderate to severe osteoarthritis of the knee, results of a 24 weeks randomized control phase 1 study. So there is concordance and replication of data between the preclinical and clinical trials with regards to the Wnt pathway. What about nerve growth factor molecular pathway? NGF has been assessed in mouse models and shown positive outcomes with TRKA-D5 inhibition and as well after active immunization targeting nerve growth factor. Both intervention attenuates chronic pain in osteoarthritis joints of Morin. The same finding was replicated in clinical trials, as we can see here in the right-hand side. Tanezumab monoclonal antibodies against NGF has been shown to be effective in reducing osteoarthritis pain after 2 doses with different dose level. Here we have fibroblast growth factor receptor 3 molecular pathway. In the preclinical studies, fibroblast growth factor receptor 3 inhibits osteoarthritis progression in the knee joints of adult mice. The same finding was replicated in humans with this famous the forward randomized clinical trials. This is a 2 years study, and it was found that intra-articular injection of sprifermin increased the cartilage thickness and reduced the WOMAC pain over 2 years. The last molecular pathway we'll discuss here is interleukin-1 TNF inhibition. So preclinical studies for IL-1 and TNF have not shown any benefit, and therefore it is not surprising that multiple clinical trials, as we can see here in the right-hand side, for both of them failed to show any beneficial effect with regards to pain or cartilage thickness. So for the 4 molecular pathway discussed with regard to preclinical osteoarthritis target studies versus clinical data, WNT, NGF, and FGFR3 demonstrate promising results in both preclinical and clinical studies and possible utility as targets for osteoarthritis, as we can see here, with positive and concordance and replication of findings in both preclinical and clinical trials, while interleukin-1, TNF have failed to show any preclinical or clinical benefit in osteoarthritis. To wrap up, there are many possible targets affecting different pathways of osteoarthritis, and we have covered the evidence on just a few of them, but more research is ongoing into other targets in osteoarthritis. As we can see here on this slide, we talked about FGFR3 agonist, WNT antagonism, both of them validated in preclinical and clinical studies for tissue repair. We talked about anti-NGF, and it has been found to be effective in alleviating pain on osteoarthritis, both preclinically and clinically. There are validated and promising studies in mouse animals with regard to CCL2 and CCR2 inhibition, and also ADAM-TS5 inhibition, waiting for validation in humans, and there are ongoing studies with this regards. So, to summarize the first part of the presentation, the preclinical studies, murine models have value in target discovery in osteoarthritis. Concordance and replication between preclinical and clinical data is high. Replication of current studies in the future is desirable. Exciting new targets are awaited as well. Now, we will move to the second part of the presentation, testing new targets for osteoarthritis in early phase studies in humans. Here we have osteoarthritis targeting cartilage. The forward trial, phase 2 trial, recombinant human fibroblast growth factor, the sprifermin, after intra-articular injection of different dosage and the follow-up over 2 years. The higher the dose given, better cartilage thickness, as we can see here. Here we have the same study presented at ACR Convergence 2020, long-term efficacy and safety of intra-articular sprifermin in patients with osteoarthritis. The result from 5-year forward study. As we can see here, this is intention to treat study with 549 patients. The 5 years data and change in WOMAC pain. The 50% improvement in WOMAC pain at 2 years was maintained to year 5 in all cohort in the intention to treat population. As we can see here, the last dose was given at around 18 months, and the beneficial effect was maintained at 5 years. Summary of 5-year results. Forward is the longest disease-modifying osteoarthritis drug study reported, with an extended 3-year observation period after the primary 2-year treatment period. Clinically meaningful difference in WOMAC pain was sustained to 5 years. No patient in sprifermin 100 microgram Q6 months group had partial or total target knee replacement. No detectable systemic safety signals. Sprifermin at dose of 100 microgram Q6 months significantly increased total femorotibial joint cartilage thickness. There is potential, of course, for target dose and potential population for the future as a phase 3 studies. In fact, there are limitations to this study. The year 5 analysis were exploratory. Subgroup risk analysis were post hoc with relatively small numbers. MRIs were read in several batches, and reading methodologies differed between time points. OA targeting bone, cathepsin K inhibitor. This is a phase 2A randomized control trial of 70 patients followed for 6 months. As we can see here, compared to placebo, 2 dosage form given, 100 mg and 200 mg. with regards to the bone, the subchondral bone, reduction in bone area increase for both doses. Here we have the cartilage. There was trend for reduced cartilage thickness loss for both doses, but there was no change in pain scale at 6 months. This study of zoledronic acid in patients with osteoarthritis with documented bone marrow lesions. So only patients with documented bone marrow lesions on MRI at baseline were included in the study, which is a randomized controlled study. Patient received a single dose of zoledronic acid and followed for 2 years. So result after 2 years was negative for both change in BML lesions or WOMAC pain. So what about targeting inflammation on osteoarthritis? So we all know intra-articular steroids works for a good number of patients with osteoarthritis. So this is triamcinolone extended release repeat dose trial in knee OA. It is an open label study. What is interesting here that repeated injections after the first injection, after either 12 weeks, 16 weeks, 20 weeks, and 24 weeks, all of these dosages at different intervals works in alleviating and reducing the pain of osteoarthritis. Here we have this study still targeting inflammation with systemic corticosteroids. We know oral prednisone was tried in the past with a smaller dose like 5 mg. It was not effective. This study tested 10 mg. This is a randomized controlled study. It is called the HOPE study. So patients with hand osteoarthritis were given 10 mg oral daily compared to placebo for 6 weeks, then taper to 5 mg and stopped after 8 weeks. There was a beneficial effect with regard to reduction of pain over the study period, but this effect was lost quickly. The other concern with regard to this study is the dose of prednisone, which is 10 mg, a little bit high, and we should be concerned with the side effect of systemic corticosteroids. Targeting interleukin-1 with lutikizumab. This is the ILLUSTRATE-K trial. It was a large randomized trial with 16-week endpoint. Pain improved at 16 weeks only with 100 mg. The conclusion of this study, there was limited improvement in WOMAC. There was lack of synovitis improvement. It was not effective as analgesia or as anti-inflammatory in OA knees, and these findings are supported by other trials in IL-1 inhibition before. So this study was negative. Still targeting inflammation in patients with osteoarthritis of the knees. This is the PROMOTE trial, which is a randomized control trial of 6 months, looking to the overall knee pain over the last week. So at 6 months, the primary outcome achieved, but treatment effect is small, and it was unlikely to be clinically meaningful. What about secondary outcomes in the same study? So the WOMAC function and the WOMAC stiffness was achieved. However, WOMAC pain was negative. As discussed earlier, Wnt signaling pathway has an important role in patients with knee osteoarthritis with regards to synovitis, cartilage degeneration, and other processes. Osteoarthritis targeting inflammation. Here we have an example of Wnt pathway inhibition, loricifivint, phase 2A trial. This is a large study of 455 patients after intra-articular injection with different dosage and assessment at 13 weeks intention to treat trial. The WOMAC pain for the whole group was not significant. However, for unilateral symptomatic without widespread pain, intra-articular injection of 0.07 milligram resulted in numerical improvements in pain, function, and medial joint space widening compared with placebo. So, this group of population may be a target for future validation studies. Targeting nerves in osteoarthritis, like NGF, nerve growth factor blocking, this is the most successful therapeutic pathway in new osteoarthritis targeted therapy. Tanezumab, which is a nerve growth factor inhibitor given as subcutaneous injection, tested in a phase 3 trial of knee and hip osteoarthritis. This was in 2019. Compared to placebo, the tanezumab 2.5 milligram and tanezumab 2.5 milligram change to 5 milligram was achieved as co-primary endpoints at 16 weeks for WOMAC pain, WOMAC physical function, and patient global assessment of osteoarthritis. Same findings were replicated in this 2020 study of tanezumab phase 3 in knee and hip osteoarthritis. This is a large, more than 500 patient randomized controlled trial of using tanezumab in two dosage form, 2.5 milligram and 5 milligram subcutaneous injections against placebo. The primary endpoint was achieved at 24 weeks for WOMAC pain, WOMAC physical function, and patient global assessment osteoarthritis. This is another study targeting nerve with the TRKA inhibitor randomized controlled trial of 100 patients. So 50 patients in each group. The treatment group received single intra-articular injection, and after 4 to 5 weeks, WOMAC A1 and WOMAC A pain assessment both improved. The drawback on this nerve growth factor inhibitor is that cartilage degeneration may be accelerated in this group of patients. Here we have an abstract that was presented at ACR Convergence 2020, efficacy of tocilizumab in patients with hand osteoarthritis, double-blind, randomized, placebo-controlled, multicentral study reported from France. TEDUA study, tocilizumab in patients with digital osteoarthritis, conducted in 11 centers in France over 3 months. Study population, hand osteoarthritis meeting the classification criteria of ACR for hand OA. Intervention, 2 intravenous infusion of placebo or tocilizumab 8 mg per kg given at 4-week interval. Outcomes, primary outcome, pain measured at week 6, not achieved. Secondary outcomes, including morning stiffness, PGA, number of painful joints, number of swelling joints, functional index of hand osteoarthritis, Cochin hand function scale, all not achieved. So this is a negative study. Summarizing the clinical data, some new therapies are promising. Inflammation may have a role in pathogenesis. Outcomes often site-specific, hip versus knee versus hand. Results may not be applicable to other OA sites. Overall summary and conclusions. Osteoarthritis is the most common joint disease and is a major cause of disability and impaired quality of life worldwide. There is still significant unmet medical need for therapeutics in OA among all MSK disorders. Many preclinical and clinical studies are promising. Novel disease-modifying osteoarthritis drugs that both inhibit structural disease progression and improve symptoms are in the horizon. By this, I conclude my presentation. Thank you so much for your attention.
Thank you so much for Dr. Faiz Al-Hathi about his informative, high-quality presentation. So just I would like to open the panel discussion to answer the questions from our audience. So I would like to start with you, Dr. Naif. The first question for you. As you know, there are a correlation between the fibromyalgia and other rheumatology disease. So based on your viewpoint, what do you think the best drug choice or option in fibromyalgia patients?
For patients with fibromyalgia, usually the treatment should be guided on the symptoms. And, usually what I usually do is divide the patients into two groups, those who have predominant pain versus those who have other symptoms. For those who have predominantly pain, I usually give them the Lyrica and gabapentin, while those who don't, who usually have, psychological symptoms like depression, anxiety, I usually treat them with amitriptyline. And also we have not to forget the non-pharmacological treatment, the exercise, the sleeping hygiene, and also it's better to involve other subspecialties like the physiotherapy and the psychiatrist, and those mainly those who have more of depressions, anxiety, and psychological symptoms more than pain. So it's usually there's no a single medication that we can say that this treatment is the first line for fibromyalgia. It's mainly based on the symptoms. Yeah.
Perfect. Thank you so much. The second question for Dr. Badr. Dr. Badr, regarding the based on the ACR 2020 gout guideline, is contraindication to use febuxostate in cardiovascular events. So what about the normal people? Is it safe to use it?
Okay, so first of all, in the late ACR guidelines, they have not said that it was contraindicated, but they have said that there was a conditional recommendation to switch the febuxostat to any other medication if the patient has any cardiovascular previous events or a new one while he was taking febuxostat. In terms of the normal population, there wasn't any recommendations for or against febuxostat, but as we have heard in the guidelines, that febuxostat is being put as a second line compared to allopurinol. Now, this is one of the major changes compared to the previous recommendations, where allopurinol and febuxostat were on the same level. Now, allopurinol is over all other urate lowering therapy, and if it doesn't work or if there was any contraindication, that's when we could go for febuxostat and other medications.
Perfect. The next question for Dr. Faiz. Dr. Faiz, regarding the result of the forward trial, do you think that the result of the forward trial promising the future of management in osteoarthritis patients?
Thank you for the question. I think this one is the largest randomized control trial in targeted therapy in osteoarthritis. I believe it is promising. Initially, it was a 2 years study. Then patients were followed for 5 years and evaluated at 5 years. Cartilage thickness was maintained, and WOMAC pain reduction was maintained at 5 years. But it seems we need more studies to validate and replicate this large study. So the future is promising, but it needs more validation. As we know, we are in phase 2, phase 3 trials in these targeted therapy.
Thank you so much. The next question for Dr. Al-Ghanem. Do you think that immune suppressive therapy is implicated to reduce the fatigue symptom in lupus nephritis patients?
No, usually, most of the immunosuppressive treatment fail to treat fatigue. We know that, steroid, rituximab, they all failed to reduce fatigue symptoms, whether it's in lupus or non-lupus. The question is, with the study that I have presented, is why patients with lupus nephritis have less fatigue than patients that don't have lupus nephritis. There could be a confounding factor. We know that when you look back at the patients who have lupus nephritis, they were more likely to receive such social support compared with those who don't have lupus nephritis. This could be a confounding factor in the study. The other confounding factor is that patients who don't have lupus nephritis, they were taking NSAIDs, and there were previous studies before that showed a relationship between NSAIDs and fatigue. So there could be that the NSAIDs were more likely cause of fatigue in patients who don't have lupus nephritis. Again, those could be a confounding factor. This is maybe the first study that looked at the difference of the symptoms of fibromyalgia between patients with lupus nephritis and those without lupus nephritis. We may know in the future, if there are more studies in the future looking at the differences between the subgroups of lupus and the differences of fibromyalgia between those subgroups. So no, I don't think we should treat fatigue symptoms with immunosuppressive treatment. There were some older studies that showed maybe hydroxychloroquine reduce the fatigue symptoms, but for now, no, we should not use immunosuppressive to treat fatigue symptoms.
Okay, thank you. Next question for Dr. Badr. What is the major difference between the new ACR 2020 gout guidelines and the old other guideline?
So basically, if we compare it to the 2012 ACR guidelines, where they have put certain scenarios, about 9 scenarios, which have graded the severity of the gout and the tophaceous gout in those patients. And based on that, the treatment was titrated according to those burdens. Basically, we don't have that in the latest 2020 ACR guidelines, as well as adding the suggestion to start the urate lowering therapy during the acute attack flare of gout, for the reasons that I have mentioned previously. Now they're recommending that the prophylaxis goes on for 3 to 6 months. Previously, the recommendations was that if a patient comes with an optimum level of urate level, the prophylaxis can be stopped by 3 months. Now they're trying to extend it up to 6 months in order to prevent further attacks, as well as stressing and strongly recommending starting allopurinol over any other urate lowering therapy. Now we've known that this had come because of the CARES trial that have said that there was increased mortality rate with febuxostat, but now in the with the new data, we're saying that febuxostat has a similar mortality rate compared to allopurinol. So I think in the future this might change some of the came out recommendations.
Thank you so much. The next question for Dr. Faiz. Any new data talking about the intra-articular PRP injection?
Okay. According to the most recent 2019 ACR guideline for the treatment of osteoarthritis, the recommendation is against using platelet-rich plasma for osteoarthritis. There is no evidence so far to use it for knee or hip osteoarthritis. So far, there is no good evidence for platelet-rich plasma, even for hyaluronic acid. The latest recommendation is also against the use of these therapeutic modalities.
Thank you. The next question for Dr. Badr. There is any role of urate lowering therapy to prevent ischemic heart disease in young male patients who have less than 1 gout attack per year?
Okay. So the gout flares are not the only marker for the risk of the increasing risk of mortality in gout patients. It's more of the presence of tophies. and the elevated uric acid level. So those should be our targets. And in one of the studies that I have presented, it shows that the overall mortality rate goes down when we start controlling the urate level and reducing the number of tophites. So even if patients don't have any ischemic heart disease, this would be a good point to look into to prevent further increase in the mortality rates.
Thank you so much. For Dr. Ghanem, I think Dr. Ghanem, regarding the same information that you mentioned about the fatigue or fibromyalgia symptom in lupus nephritis and non-lupus nephritis. So the question is, regarding any role of anti-inflammatory medication does have any role in comparing lupus nephritis and non-lupus nephritis?
I didn't understand the question. If anti-inflammatory medication has any role in...
I think even for medication or also immune suppressive therapy, I think so.
Yes, I think what they mean by the question whether the immunosuppressive treatment help the patient with lupus nephritis to have less fatigue than those without lupus nephritis. Again, we know previously that there is no evidence that immunosuppressive treatment reduce the fatigue symptoms. Maybe if the patient has a flare, yes. If the patient has a flare, of course they will have fatigue, and we should treat them with steroid and immunosuppressive treatment. But those who have only fatigue symptoms, immunosuppressive treatment will not help the patients. So did the patient with lupus nephritis have less fibromyalgia symptoms because they were on immunosuppressive treatment? It's unlikely. I think, again, there were many confounding factors. One of them, the social support, the better social support that patients with lupus nephritis received in that study, and this could be why they had less fatigue. But I don't think it was the immunosuppressive treatment, because, as I mentioned before, all the previous studies failed to show benefits of immunosuppressive treatment as treatment of fatigue.
Thank you so much. I think this is the last question for Dr. Al-Harthi. You mentioned in your presentation some of negative trial about the use of or effective some medication like IL inhibitors and disease-modifying anti-rheumatoid drugs like methotrexate and also steroid at the endpoint, that it wasn't helping treatment to the patient who have osteoarthritis. So do you think that it will change some behaviors of our staff that they use this medication?
I hope so. We know most of studies like for methotrexate were negative. For steroids like systemic corticosteroids, the study presented with 10 milligram. It was short-term benefit in patients with hand osteoarthritis, and we know 10 milligram is a little bit higher dose, and toxicity is a concern in these patients, and the effect is usually lost immediately after the stoppage of the treatment, so they are not indicated. IL-1 inhibition and TNF inhibition both fail to show any benefit preclinically and clinically, so they are not indicated for patients with osteoarthritis. Hopefully in the future, we'll have some of these phase 3 new targeted therapy validated and approved.
Thank you so much. I think it was the last question for the panel discussion. Really, I would like to thank all of you for joining us tonight. I think we have reached at the end of the day. I would like to thank all the speakers and chairperson for their informative presentation. Also, thanks all the audience for their attention, and I wish you enjoyed in the previous meetings. Big thanks for all the staff who are working in the backstage, especially for Anchor Company and the platform team. Hopefully to see you again tomorrow in the last day of Best of ACR Convergence 2020 Saudi Arabia. Thank you so much and have a good night.